righty. Y'all say so. But I did forget it this time, really. All right. Here we go. This is just leaving off on chapter 8. I'm going to share my screen. Make sure I'm recording. Communicating with instructors and staff. Okay, I think we started at that point here. Can y'all see my screen?
Yes.
Okay. When communicating with instructors and staff, we need to pay attention to, and this is on page 115, how we respect, trust, honesty, empathy, sensitivity, humor, knowledge, patience, commitment, self-esteem, thoughts and straightforward communication, iMessages. And you all can read through these different types of communications, but I can say that commitment is incorporating all the previous characteristics, staying committed, do what's necessary to get the job done. Self-esteem is earned, it's not learned. iMessages, you should use iMessages effectively. It allows the receiver, I got my spelling all screwed up here. Using iMessages are less defensive. Using you messages, starting off with you, causes the receiver to be on the defensive. So practice when you're communicating with people, staff, instructors, or patients. Don't use the you word, because actually the you word is basically saying that that person is guilty of something. You're putting that person on blast. So just kind of be aware of how you use your iMessages and your you messages. When you treat yourself with respect, it's easy to extend respect to your instructor, to patients, and to staff. Your patients quickly pick up on whether or not they're being respected in a conversation. So learn how to use your body language, use the right kind of body language, learn how to answer questions appropriately. Practice at home on how you would answer a patient's questions, or learn how you would get something over to a patient. If you were providing teaching or instructions, or even talking about something as serious as their illness, their spirituality, and their culture. Just kind of be aware of how you communicate. And the best way to do that is to practice at home and just think ahead of how you'd respond to certain things. Trust begins with your own confidence to make decisions. You do this by consistently doing the required preparation for assignments. Preparation, knowledge, and willingness to seek out info when needed contributes to a trusting relationship. So the more you know, the more confidence you have to make decisions, and the more self-esteem you have, and the more your patients will trust your judgment. Honesty, you will not I can't be writing here, guys, sorry. Oh, let me go with arranging time with your instructor. This is in regards to honesty. For you to repeat a procedure is an example of honesty. Your honesty and your feelings of not being sure of how to do things or what to do. So you're seeking out making time with your instructor or your peer to repeat a procedure you're not familiar with. Empathy is the ability to understand and appreciate what someone else is feeling without experiencing the emotion itself. You could have empathy for patients, but you shouldn't be so sympathetic that it causes you to um, not care for them in the way you need to care for them and to get too emotionally attached to a person. And I'm going to tell you, as nurses, as you become nurses, I'm sorry, there are some patients in your lifetime in nursing that you are going to get attached to. Try your best to not do that, because you can't really help a patient if you're crying along with them, or if you're more self-absorbed with what's going on than the patient himself is going through. So learn how to be empathetic. It allows you to understand how someone is feeling and why they feel that way, and to maintain control of your own emotions so that you can think clearly and care for them appropriately. Y'all got that? That's a lot. Sensitivity. Um, it's tuning in on nonverbal and effective communication. It permits you to check a patient out with staff and your instructor. Uh, for instance, is there something else I show? I'm sorry. Is there something else I should know or look at regarding this patient? So you need to be self-aware, be sensitive, and open to nonverbal and effective communication, so you can really read your patients and assess them appropriately. Healthy humor is always good. You come in with a smile. Uh, Even when a patient's mad or upset, it can change the groundwork and the introduction for you and that person if you come in with humor and with a smile. Knowledge is self-explanatory. Be prepared, gather your data, prepare for patient care. Patience. Sometimes it's difficult to provide time needed to learn and receive explanation from instructors or follow staff orders. This extends to our work with patients because of illness, growth and development levels, which will generally dictate the need to slow down or repeat direction. So sometimes you have to learn how to be patient in the midst of having 8 patients. You have to learn how to slow down and talk to your instructor if need be, your staff, people you work with, or with your patients, because some patients might need your patience to explain different things to them, especially if it's a patient who has an impairment, or a patient who's from another culture, or a patient who's or not or a person who's not connecting with you, or a depressed patient, or a patient that is grieving. So learn how to be patient. And like I said, that's on page 115 if you want to look further into that. Okay, we're going to talk about something that's very, very important that you all will be doing next semester, and probably toward week 10, 11 through 16. It's called the S-bar, which is situation, background, assessment, and recommendation. Those are what those words mean, okay? The situation and background assessment and recommendation was first developed in the military and has been adopted by many healthcare institutions to facilitate clear communication. So you all will probably be doing S-bars when you get into clinic. And you'll also be doing S-bars as you become nurses, as you change shifts, as patients go from transferring from one place to another place and you're giving report, you're going to more than likely use this type of documentation, the S-bar. Okay, let's go with the situation here. Situation is identifying who you are, the unit, the patient's name, the room, and the problem. Background is admitting diagnosis, the date of admission, the status of the patient, their mental status, their vital signs, medications that they've been on, their allergies, whether they're on IV fluids, their code status, information related to their current status. So all of these things that you're looking at in regards to background. Assessment is what's going on based on evidence. Is it life-threatening or not? It's based on signs and symptoms. If you are not comfortable with the assessment part of an S-bar, you should collaborate with the RN. Assessments is also what you guys do when you do the head and toe assessments, when you're doing your nursing notes. It's basically what's going on, what you see, what you hear, what you feel, what you smell. All of these things are part of the assessment. Recommendations, which is the R part of it, is what you need from your physician. S-bars are usually used to communicate with the doctor. Say, for instance, you get a new patient or you need to talk to the doctor and he's elsewhere at another unit, or he's at home, or he's in surgery and you're doing you're leaving a message for him, you would leave it as an S-bar. Recommendations would be what you need from your physician. Terms like, could it be, it might be, do you want the MD to come see the patient? Do you want an order for medications in case the patient's in pain? Do you want to transfer this patient to a higher level? Maybe this patient is getting worse and he needs to maybe go into an ICU type facility, or he might need to even go to be transferred. If you're working in a clinic, he might need to be transferred to the emergency center. So this is where you would use your recommendations. This is you telling the physician what you need for this patient. And also, do you need a patient consult? Say, for instance, the patient has some problem with swallowing. You might want to tell the doctor, I've noticed that this patient's really having trouble swallowing his pain medicine. Can I get a consult for ENT, ears, nose, and throat specialist? So this is how you communicate the S-bar with the doctor. Giving report. Giving report is like a shift report. You're going to use the S-bar for shift reporting. That's when you transfer a patient to a different unit. A patient is leaving the clinical unit. The patient is going to ICU. Maybe the patient is going to OR. Anytime the patient is leaving you, or you are leaving the shift for the day, or even on lunch break. you need to use the S-bar shift report. They're similar, but it's a little difference in the two. It's still situation. You would tell the nurse their chief complaint, the patient's chief complaint. It's the diagnosis, the admission date in which he was admitted into the hospital or onto your unit. Background information would be the patient's medical and social history. The patient might be diabetic, he might be asthmatic, he might be homeless, he might be a divorcee, it might be a single parent, whatever their social history is, you'd want to relate to that oncoming shift. You definitely want to make sure that you give a report of the patient's allergies. You would always give a report on a code status of the patient. If the patient was to be on isolation or if the patient was on isolation, you want to make sure that you let that nurse know that I have a patient coming to you, he's on respiratory isolation, it started such and such date, and that he's been taught isolation precautions. You definitely need to let the nurse know if a patient's on isolation. So that nurse can in turn prepare a room with isolation equipment. Okay. You want to talk about pain management and response to the pain management and the intervention. Say, for instance, the patient was in pain, you tell the nurse, and you gave the patient Demerol 30 minutes before it was time for him to be transferred. You tell the nurse, patient complained of pain. On a scale from 0 to 10, he complained of a pain scale of 8 in his left lower abdomen. I gave him Demerol 20 milligrams IV or PO at this time. And you could also tell them, has that patient responded? Has the pain gotten better? Has it gotten worse? Is it the same? And what time you gave it? That's very important when you're passing on shift information. You would want the nurse to know if this patient is a fall risk. Has he fell in the past? Is he an actual fall risk? So the nurses will know what to do on the unit for that patient. You want to let the nurse know the ADLs of the patient. Is the patient able to walk without assistance? Does the patient need to be a two-person transfer? That's something that's very important. Is the patient wheelchair bound? Does the patient have a cast? You know, those types of things you need to let the nurse know. That's all in the assessment of a patient. Recommendations would be the patient's goal. What is the goal that you're trying to accomplish? What needs to be done on the next shift? Say, for instance, the patient didn't get a particular lab. You'd want to say to the nurse, the patient was supposed to get a CBC, but we couldn't get any blood out of his IV because it infiltrated. So this patient will need to have labs drawn on your shift. This patient might need to be pre-op tonight for surgery in the morning. Any procedures that must be done and procedures that hasn't been done but should be done on the next shift, that's a recommendation. And also, if the patient is being discharged on that next shift, you might want to tell that nurse that I educated this patient on such and such and such. He is to be discharged tomorrow or tonight to home. If there's anything he needs in regards to medications or devices at home, whether he needs to go home at O2, whether he needs to have a wheelchair and stuff like that. All these are things you need to report off to the next shift applies. Oh, another thing I failed to mention is that if the patient has a peripheral IV, which is an IV in the arm, you want the nurses to know that this patient has an IV in the left arm. This patient has two IVs, one in the right arm, one in the left arm. This patient has a central line. This patient has a JP drain. This patient has a colostomy on his left side. This patient has a wound on, or he has a decubitus on in his sacral area. He has a skin tear on his left arm. This patient is on oxygen at such and such and such. This patient has a urinary catheter. These are things that you need to let the nurse know when you're giving report, so she can be prepared for all these different scenarios. Y'all got all that? I know it's a lot, but there's a lot in shift reporting, and it sounds like a lot, but when you get really good at doing this, you'll know what pertinent information to have for the doctor and what pertinent information you'll have to report to a shift going off. So just letting you know. And one thing about nurses, when you fail to give them the right information, when you're transferring a patient to them or you're changing shifts, you tell them you missed that they have an IV, and she comes in and she finds that the patient don't have an IV. The IV is infiltrated. The person has an NG tube that you didn't mention. A patient had a catheter and he had bloody urine in the bag, stuff like that. You need to report to your nurse or you will definitely get hounded for it. You know, nurses don't like surprises. So just letting you know that. And let's see what else. Lifespan communication. Learn that different communications are individualized. It works. There's different communications for infants, preschoolers, school-age children, teenagers, adults, elders, and generational differences. So you kind of need to know how to communicate with these various ages and generational differences. So you can read up on that. Conflict resolution. You know, to accept conflict as a natural part of life. Every nurse is going to have conflict, whether it be with a doctor, whether it be with their peer, whether it be with their instructor. They're going to always have some sort of conflict. It's how you resolve it, okay? Temper your own attitude and behaviors. Take time to think critically before you react. Think about what you say and do before you react. Treat conflict as an opportunity to voice your own opinion and listen to the other side of the story. Remember, two-way conversations are better than just one-way conversations. Choose your approach, how you're going to explain the conflict that you're having. Listen to that person and learn. Discover the core issues, what the issues are. It might be as simple as a person's feelings got hurt. It can be unmet needs of the patient or from a staff member. Respect each other. Treat other people that as you want to be treated, okay? And then you're going to find common ground to resolve conflict resolution. Have any questions about any of that? Oh, and electronic communication. One last thing. Electronic communication, emailing, cell phones, text messaging. I need y'all to look at box 8.1 in your book. I don't know what page that's on, actually. But it
119.
Okay, 119. Okay, email messaging. Use effectively and appropriately. You need to learn email etiquette. So I think that's what's in box 8.1. Consider the content you're sending. Be sure to use a subject line. There's nothing worse than people sending me emails that don't have a subject line. Because if it don't have a subject line, guess what? I'm going to ignore it. Just go be honest with you. I'm going to ignore it because you need a subject line. Be specific. Avoid useless information. Keep your sentences short and paragraphs short. Avoid sending confidential information unless your email system is encrypted, which means it's unavailable to third parties. It's usually this information is usually sent using a secret code rather than insecure plain text. Most of all of CHCP information is encrypted. So I would suggest not to use CHCP email as a personal email for yourself. Do not do that. That's against policy. And you need to verify policy and procedure wherever you work. That's very important so that you don't do something you're not supposed to do. Cell phones. Do not text during class. It distracts the providers, the instructors, and peers, and it's very impolite. Some students use it as a way to cheat on exams. It's disrespectful, and you are not to receive text during clinical, workplace, and classrooms. In a real clinical setting, it's generally prohibited to use a personal cell phone. They usually tell you you need to go outside the clinic area to use the cell phone, but a lot of places don't allow you to have the cell phones on you, and you can get written up if it's not on silent or you're answering your phones while you're on duty. Read your job policy on these things. Make sure text is going to the right person and no confidential information is being leaked. No pictures with staff or patients' permission. Another thing that's been important is like people want to, you'll find yourself working in a hospital where patients want to take pictures of you. Patients have to have your permission to take pictures of you. You have to have your permission to take pictures of your patient. But to be true, you really shouldn't be taking any pictures of your patient. That's really a HIPAA violation, so don't do it. But some family members sometimes want to come in and take pictures of what you're doing to the patient. That is prohibited. If you have a problem with that, talk to your RN or your charge nurse because they're not supposed to be able to record you. So I want you all to know. Okay, so that's that on, so I'm gonna stop the share for a second and we're gonna follow.
Thank you so much. I'm sorry, I just got back from the doctor's office. Can y'all fill me in on what we're doing? Sorry.
Nurse Jackie told us to hold on for a minute. So we're
Can
holding
y'all
on.
hear me?
Yes, we were in chapter 8 and she was just finishing what we were on last week. And I think we're going on to something else right now.
Oh, okay, thank you. I'm sorry.
No problem.
Oh, okay, it looks like everybody.
Yeah, we're all waiting.
Okay, thank you so much.
Nurse Jackie told us to wait for a minute. Can y'all hear me?
Yeah, I can hear you. Thank you.
Oh, the yellow box wasn't
But
around.
it's like cutting off.
Oh,
Can y'all guys
everybody.
hear me?
Now we can.
Oh, you know what?
I hear
Okay,
you, but it's like
what I'm on is your learning objectives. Make sure that
What?
you know these learning objectives for week 7.
Can you make it big?
Yeah, I can make it big. Hold on.
Thank you.
Is this chapter 10?
Oh yeah, this is week 7, chapter 10.
Okay, thank you.
Okay, here are your learning objectives. Can y'all see that?
Yes.
Okay, so you definitely need to know these things. You're gonna have to know different cultures in the areas of the family, religion, communication, educational background, economic level, wellness, illness, birth, death beliefs, and practices. You're gonna have to know this transcultural model. It's in a box in this chapter. You're gonna have to be able to explain in your own words the philosophy of individual worth as it applies to healthcare. Describe general differences and stereotypes among cultural groups frequently served in your geographic area that may have importance in patient care situations. Now, groups that we're gonna be studying that I want you to be well aware of are Muslims, Chinese, Hispanics, Afro-Americans, Native Indians, who else? Vietnamese, Easterners, Muslims, people from Afghanistan. All of these people, you may not live around them, but I'm sure you've been around them. And you all will have to learn the various differences and the cultural groups and be aware of the family, how their family life is, religion, communication, all of this information, how it all applies, including religion. Explain the importance of awareness, knowledge, information, and collaboration in developing an ability to provide cultural competent care. So all these things you will need to know in this chapter. There are a lot of tables in this chapter that will help you with the various religious groups, the various cultural groups and their differences. Make sure that you know this because there's going to be quite a few questions in regards to these various groups, like what would a kosher diet consist of? Which particular culture would have or need a kosher diet? Something like that. So you need to know these things. The other learning objectives, which is in chapter 11, you'll have to differentiate between spirituality and religion, identify the difference between the spiritual and emotional dimensions of individuals. All this is in you all's PowerPoint. Discuss the role of the licensed practical nurse in providing spiritual care to the patient and the family as a member of the healthcare team. List members of the healthcare team who can help provide spiritual care for patients. Discuss key nursing interventions to meet the spiritual needs of patients. It's a table for that as well. Discuss personal religious and/or spiritual beliefs or the absence of them and how these beliefs will influence nursing practice. There is also a table for that. Discuss the general beliefs and practices that account for the differences among various Western, Middle Eastern, Eastern religions, philosophies, and groups in the United States and Canada. So there is a table for that. Describe nursing interventions, considerations of patients of various religions, philosophies, and groups. All of these have tables. And as we go through this, I'll let you know what table it is, okay? Because this is a lot of information. Okay, definition of culture. Culture is a person's way of life. It's their thoughts, their ideas, beliefs, values, communication, food, attitudes, and traditions. It also includes standards of behavior and sets of rules to live by. It is learned behavior that is passed on from generation to generation. So with these different tables, you all will need to know ideas, beliefs, values, how they communicate, food, attitudes, and traditions, as well as their spirituality and practices. Cultural competence is the continuous attempt of nurses to gain knowledge of a culture. Cultural sensitivity is being patient and tolerant of other cultures. Customs is the general accepted ways of doing things that are common to people who share the same culture. When differences are identified in a healthcare situation, the nurse should suggest adaptations to the plan of care so the plan recognizes these differences. In doing so, the patient will be encouraged to follow suggestions. This will avoid treatment failures and return the patient to health as quickly as possible. Because when a patient is from a different culture and you're not understanding their culture and you want to do things that are really indifferent from what they're used to, it's going to interfere with their plan of care, which is not going to help them to heal. So it's very important that, I think I mentioned to you guys before, make sure that you take a cultural sensitivity test to, well, not a sensitivity test, but there's actually an in-service, and read these different boxes so you can have an idea of different cultures and interventions involved in caring for these patients and communicating with these patients. Most hospitals do have a cultural sensitivity in service for all their employees. It's really mandatory. Characteristics of a culture. Enculturation. It's the process of learning your culture, the way your group does things. Worldview is similar ways of seeing and understanding the world and is the reality of the group. One's worldview can lead to ethnocentrism, prejudice, and discrimination unless modified by knowledge and experience. So it's very important that you learn these different cultural biases, their stereotypes, so you won't become one of those people that will stereotype or be prejudiced or discriminate against the culture because you don't understand it. Socialization is the process by which a person of a culture learns to function in another culture. An example of this is you're being socialized right now into the career of practical nursing. You just don't know it. You know, you may be unconscious of it, but you are being socialized into becoming practical nurses. So make sure you know the characteristics of culture. Danger, ethnocentrism, prejudice, and discrimination. These are all dangerous for taking care of patients. Sorry, let me go back a second. Okay. As I said, ethnocentrism is feeling that your culture is better than another culture. The group is uncomfortable with people who display customs and behaviors that differ from their cultural group. The United States is very ethnocentristic because for some reason, a lot of us believe we are the best and we do things the best and we are the best. That's ethnocentrism. We can always learn from different cultures. The United States is a melting pot, which means that we are now, we have so many different cultures interlaced into our own culture that it's very important that we learn and are sensitive to a patient's differences and uniqueness. Prejudice. It's the opinion you have of someone even when facts aren't in a line or substantiated. It's being intolerant of another culture. It can be conscious or unconscious. You might not even be aware that you're being prejudiced. You might not be aware that you're discriminating. So discrimination is withholding privileges because of prejudice. Stereotypes are assumptions based on a group without exceptions. Stereotypes can be harmful. You should view a patient as an individual and find out his cultural preference. You need to learn how to use a cultural assessment tool to help with stereotyping. Let's see. Prejudice can undermine patient care. Example, a male doctor being less likely to take a woman's pain seriously. Research has shown that they might believe a female patient exaggerates their pain or is overreacting. And that, we talked about that in another chapter where a lot of male doctors have a different way of looking at and sometimes caring for female patients, because after all, they're not females. So they really don't sometimes understand the female psyche. So it's and that leads to prejudice.
I'm sorry. I was gonna say I actually would rather a male doctor because they don't understand, and so they're more, to me, they're more sensitive to your needs because they don't experience your pain. So it's like, well, I'm just gonna take your word for it. Versus a woman, she's like, oh, I felt them pains before. In her mind, oh, you ain't in that much pain. Oh, you're overreacting. You're being dramatic. I'm a girl too. That kind of thing. So I would actually rather a male doctor because
sometimes women doctors can be prejudicial too, because they think just because they're female and that they've been through the same thing that you've been through, that, oh, I handle it, why can't she handle it? So you have to be very conscientious about how you treat patients in regard to their care. So definitely know and understand these terms. And another an example of prejudice can be racial prejudice, as we all know, against people of color, and ageism, being too young or too old. You know, a lot of places won't hire older people, even though they might be more experienced. They won't hire them because they believe, well, in 2 years, they're going to retire, and then we'll have to spend all this money to teach somebody young, or we have to pay this person more money because he's more experienced. You know, all of those are examples of discrimination and being prejudiced. Same way with young people. Some people might not hire young people because they think that they're inexperienced. They may have a degree. They may not have been out there, you know, in the workplace, but they have a degree proving that they are capable of learning, and some places won't hire them because they're too young. So you just never know. Some places won't hire people with disabilities, and that is against the law, by the way. I mean, to discriminate because of a person's
Federal law.
gender, sexual orientation, all of this is against the law, if it can be proven. See, that's the secret, if it can be proven. Because I was in a position, I'm gonna say this real quick. I was in a position that I was interviewing this lady years ago, and she was perfect for the job. We thought she was great, but she made the mistake, and it wasn't a mistake because she was being honest. She said she had MS, multiple sclerosis. She was not hired because of that. But that could not have been proven. That could not have been proven. My manager had the last say on this, but I knew why she wasn't being hired. They hired somebody else who did not have any illnesses, or they did not mention a particular disability. So a lot of people these days, when they ask about disability, do you have a disability? They say no, because they're afraid that people will discriminate, which sometimes they do. So I just want you to be aware, have your own personal awareness of, are you that type of individual? How do you avoid being that type of person? Men,
Also, I'm sorry.
what you said?
Go ahead. I was gonna say sometimes, like, you know, if a person, it doesn't matter what job it is, if they were, like, if they're pregnant, or if they're married, or if they're unmarried, or if they have kids, like, you know, you don't mention your kids, that you have kids in the interview, because of the fear of being discriminated against. Some people may feel like, oh, well, she's got kids, she's gonna be calling off a lot, her kids are getting sick, you know. Or if you mention you have a child with a disability, oh, she's gonna be calling off a lot. We can't pick her. Let's pick somebody that don't have kids, or that's single instead of being married, you know.
Yeah.
Probably work harder or give them more hours.
You need to be aware of those things. You need to look at your own prejudice, your own stereotypes on different cultures, and whether you discriminate, because sometimes you might not even be consciously aware of these things. Men making more than women in spite of the same experience and qualifications. How often do we hear that? Men make better
all
nurses.
the time.
Men make better nurses than women. How often do we hear that?
I don't hear that.
I don't hear that.
No. To be quite honest, in my opinion, which is kind of my own little stereotype, that I found, not that I'm discriminating, I found that men are more anal. They pay attention to detail. They're just very analytical is the right word. That's why if you notice in the emergency room, you see most males in the emergency room because
That's
they're
true.
analytical. They're you know, I don't want to say they're insensitive, but they kind of put that aside, their sensitivity and emotional being aside, and focus on what's at hand. So that can be considered discriminative. And sometimes, you know, there's so many different types of stereotypes. I just want you guys to be aware that, and look at yourself and make sure that you're not being one of those, because that's very dangerous to your patient. Thinking like an anthropologist. Okay, I'm gonna run through this real quickly. It's on page 138. You need to know communication differences. You need to know about space, social organization, time as it refers to the present, the past, the future. Anthropologists have determined there's 3 types of time zones for patients. Some patients live in the present, some patients live in the past, some patients live in the future. That's on 138. Look at what type of person, what type of time person you are. You'll find that quite interesting, actually. Environmental controls, whether it's internal or external. Biological variations, body structure, hair type, skin characteristics, race, incidence of specific diseases. I mean, like, does one race are more prone to a particular disease than another race? All of those things are what anthropologists look at when they're studying cultural differences. Make sure you look at box 10.1, once again, the transcultural assessment model on page 138. That's very, very important. Know yourself. What makes you unique? How many hats do you wear? What do we share in common? Okay, definition of critical reflection. Nurses shall engage in critical reflection of their own values, beliefs, and cultural heritage to have an awareness of how these qualities and issues can affect cultural congruent nursing care. And this comes from the standards of practice for cultural competent nursing care. And that's on page 41, in case you're interested where that came from. Knowing others, cultural diversity. Know the importance of cultural diversity. Failure to develop sensitivity to and competence in handling this diversity could lead to misunderstanding between you and the patient, resulting in stress for both, and plan of treatment failure. The United States was eventually called a melting pot, meaning that these immigrants had given up their native cultures and adopted the culture of the American people. Although we have a lot of different immigrants in the United States, they come to the United States with their own cultures and they are assimilated to our culture. Some of them don't simulate all of themselves to our culture. Some of them do hold on to their own cultures. So you definitely need to understand assimilation, what they have in common with you or us, and what they don't have in common with us. Areas of cultural diversity. Okay. I want you to look at, and this is important, this is with spirituality too, this other section that I'm trying to get to, is you want to look at, when you're looking at the different cultures and the various races and groups and religious groups, You want to look at their family structure, their food preferences, their religious beliefs, concept of time, what I mentioned to you all, whether you're past, present, or future, communication, educational background, economic level, wellness and illness beliefs and practices, pregnancy and birth beliefs and practices, terminal illness and death beliefs and practices. This is all on page 145 through 147. And there is a table as well that has a box that has all this information in it. You really need to learn the tables. I cannot overemphasize that. Increasing your knowledge of cultural diverse groups. There are categories of major health belief systems. You need to know these: biomedicine systems, personalistic systems, and naturalistic systems. Rarely does a group ascribe to all the beliefs in one system. That's on page 149. Biomedicine is the belief that abnormalities in structure and function of body organs are caused by pathogens, biochemical alterations, and or environmental factors. This is the Western medicine. This is how the United States, that's what their belief system is, the biomedicine, where prevention is washing hands and covering your mouth. Treatment is with drugs, surgery, or diet. Causes of illnesses is viruses and bacteria. Who cures these ailments? A medical doctor. 2, personalistic system is the belief that a deity, ghost, God, evil spirit, witch, or angry ancestor is punishing the sick person. An example of that are Native Americans, by the way. The prevention is being faithful to their rituals. Their treatment is counteract the causes with herbs, prayer, rituals, laying of hands. The cures are by a person with magic or supernatural powers. It's not a doctor. It's usually like a rich doctor or someone that they presume has supernatural powers. 3 is naturalistic beliefs developed from the traditional medicine practices of the ancient civilizations of China, India, and Greece. They believe in MDs are herbalists. Their prevention of diseases is maintaining balance of yin and yang, hot or cold in the body, mind, spirit, and environment. Their treatments are acupuncture, coining, cupping, regaining balance to the body. Causes of diseases would be like imbalance of body elements, bad luck, yin yang, their bodies being out of balance. Like I said, wet, cold, hot, cold inside the body. So it's amazing how many different types of cultural categories or systems that we have in the United States that nurses need to be aware of. Let's see. Diversity profiles of predominant cultural groups. Y'all need to know this. Page 149, box 10-5. Southern China, Vietnam, and I think it's Laos, Laos, if I'm pronouncing that correctly.
Chatty,
Huh?
could you repeat that again? I'm sorry.
Oh, Southern China. No, Southern China, Vietnam, and Laos, Laos.
that's Laos.
Laos. Thank you,
Yes.
Laos. And that's on 149. You need to know the profiles of predominant cultural groups, such as Afro-Americans, the Hmong, which I think are Vietnamese, are the Chinese, no, the Vietnamese, Hispanics. There's different groups of Hispanic, and I'm quite sure that some of our Hispanic nurses can explain the differences, because I made the mistake of my life 2 years ago by saying Hispanics, and that all of y'all are from like, don't y'all have the same type of culture, the Puerto Ricans and the Colombians and the what did I say? Puerto
No,
Rican?
ma'am, we do not. Some of us are Mexican.
I know.
No, she said she made a mistake.
I
That was her mistake.
Totally unaware of that. I did not know. I had to
No, like me,
apologize.
I don't get offended if somebody calls me Salvadorian or Honduran, whatever it is.
Yes.
But some people get very offended. Like, my
No.
background is Mexican, but I don't really care.
I know. And you know how I found this out? Actually, I was just so upset that I had insulted this lady. You know, we made amends because she really realized I didn't know what the hell I was talking about. I have a friend who's Hispanic, and I told her about it. She says, girl, no, you didn't. I could have told you that. I said, well, why haven't you told me all these years I've known you? How come you never told me that they get offended? How was I supposed to know this unless you tell me? So y'all learn that there are so many different cultures within the Hispanic community. Know your American Indians and Alaskan Natives, your Arab Americans. You have to know their profiles because they're the most predominant cultural groups in the United States, okay? I just had to share that with y'all because I was just so embarrassed about that.
Yeah, people get too crazy over that. I don't know.
Yeah,
but it is the respect thing.
So people are very sensitive. So it's very important that y'all learn this.
Yes,
developing cultural competence in healthcare situations. Identify your agency's cultural groups. Learn how to modify your work settings. Be knowledgeable that you frequently be knowledgeable of types of individuals that are frequent in your community. So be aware of the people in your community. You know, it's not all of us no longer live just among Black people or Hispanic. You know, we live among a whole melting pot of people. And there would be less prejudice in the world if we all gained a friend from a different culture so we could learn more about them. Maybe we wouldn't be where we are today if we took the time to do that. So just letting you know, box 10.6, it's important to know that. Care planning for cultural diverse patients in your service area. I need you to look at box 10.7 and box 10.8. Gather data regarding each patient, clarify ADLs and health beliefs and practices for your patient. These boxes that I mentioned to you guys, they are care planning interventions for different cultures that adapting plans of care for cultural diverse patients. Discover the health beliefs of the individual, co-create treatment plans with the patient, preserve the beliefs and practices that are helpful to the patient, repattern harmful practices. And you need to see box 10.9, 10.10, and 10.11. This particular chapter has so much information, you guys, and you will learn a lot by these boxes. There's just no way that I could have broke down all of these different things to you guys today, and then try to tell you about what's going to be, go over the review. So chapter 11, here we go, super fast, because there's 2 chapters y'all have to know. Ms. Barker, make sure you sign into the chat, or whoever came in late, please sign into the chat. Spirituality and religion. Starts on page 156, chapter 11. Know what spirituality is. Spirit versus religion. Spirituality is one's life force. It does not necessarily include religion. Spirituality includes the beliefs and value systems that give people strength and hope related to experience, but religion has to do with giving form to that experience. So religion is spiritual experience that contains specific beliefs and rituals, and spirit is the essence of a person. Spiritual versus emotional dimension. Okay, there's the spiritual dimension, is the relationship of an individual to a higher power, and emotional needs, how people respond and deal with feelings of joy, anger, sorrow, guilt, remorse, and love. Now, not everybody is spiritual. Everybody doesn't believe in a higher power. We have people that are atheists that don't believe in supernatural powers or a God, but you still can communicate and help these people because all of us has emotional needs. So we need to learn how to deal with these people through their feelings of joy, anger, sorrow, guilt, remorse, and love. Importance of spiritual needs. It gives you inner strength, self-awareness, life's meaning and purpose, relationship to others, relationship to a higher power. Be aware of your personal spirituality. Spiritual care involves helping patients to develop an awareness of and maintain their spiritual needs. Nurses should avoid waiting for crisis situations to occur before they become concerned about spiritual care. So learn how to identify patients that are going through a spiritual crisis. Sometimes it's very hard for us, especially if we don't understand spirituality well, or we're not sure of our own spirituality. We don't know how to talk to patients when they're talking about death and dying and pain and illness. That's something you guys need to think about, your own personal spiritual needs and thoughts. And the Joint Commission, which is over mostly every hospital in the United States, requires that spirituality is assessed for all patients. So whenever you're doing an assessment on your patient or the RN or yourself, you have to ask questions. And there is a table in the book that just kind of gives you some questions on what to ask patients about spiritual assessment. Who provides your strength and hope? How do you cope with illness, death, dying? Do you have a relationship to a higher power? Do you have a religious affiliation? Those are some of the questions you need to ask somebody when you're doing a spiritual awareness assessment. Who needs spiritual care? Those in the following patient situations: a person who's hospitalized, a patient who's in pain, patients who have chronic or incurable diseases, patients who are dying, families who have experienced the death of a loved one, patients who are facing an undesirable outcome of illness, such as an amputation, patients who have lost control of themselves. So these are things you need to know as well. Who needs care of this nature? Gathering data for spiritual issues. This is on page 158. I'm not going to go through all of them. You can read about them, but how do you cope? Who is your source of support? Do you feel love? Do you have someone with whom to cry? Who gives your life meaning? Who brings you joy? Do you believe in the power of prayer? Do you believe in a higher power? Do you have a relationship to a higher power? Do you have a religious affiliation? Always kind of know what a patient's religious affiliation is, because this question, all these questions wouldn't apply to someone who's an atheist. So it's very important that you learn and you do your assessment very well on patients when you're doing their spiritual assessment, because some people can get offended about this. And you should know different cultures' spiritual issues as well, and how to assess them as well. Meeting the spiritual needs of patients. Of course, this is on page 158 as well. You're going to ask questions. You're going to listen with an understanding attitude. You're going to help patients face the reality of a terminal illness. Encourage the patient's active involvement in self-care. Allow families to participate in caregiving. Avoid false assurance. And what that means is that telling a person everything will be okay when it's truly not the case. Okay? Pastoral care team. Pastoral care team includes ministers, priests, rabbis, consecrated religious women, representatives of other religious organizations, and laypersons. Know what pastoral care team, who is included in pastoral care team. And when you're doing an assessment on a patient, a spiritual assessment, make sure if they do have an affiliation with a particular priest, preacher, pastor, bishop, that they give a verbal and written, mostly a written consent that these people are allowed to visit them. These people cannot just walk in a patient's room and see them. That's a confidentiality issue. These people need to be aware of the policies. Your patients need to be able to contact their particular pastoral care team, and you need to allow them to do so or help them to do so, but you also need their consent to do so. Because it's definitely a HIPAA violation if you just let somebody just walk into a patient's room. How patients meet spiritual needs. It's self-explanatory, once again. That's on 159. On 159, I want y'all to pay attention to a conversation between a nurse and a patient about praying. This patient wanted this nurse to pray with her. And sometimes patients will ask you that, and it might be an uncomfortable situation for you to do so. So this just gives this particular page kind of tells you how to start that conversation. But you also want to know patients.
Do that first.
Huh?
Oh, sorry.
Oh, I was gonna say, just pray with them, even if they're praying to their cat. Just stand there.
Well, you can, but they might ask you questions. But this is why I say it's important to identify your own self, your own spirituality. Because if you don't understand your own, it's going to be hard for you to understand others. And even then it's hard sometimes unless you know what's going on with that particular culture, okay?
Miss Jackie, I'm sorry. Is this class till 2:30 or?
What time is it?
It's 2:50.
Oh my God, is it? What y'all tell me?
I'm sorry. I didn't want to be rude, but I got to get my son off the bus here in a little bit.
Oh, okay, well, you can go, but we were going to discuss, we were just going to go over concepts right after this, whoever can stay. If for some reason, well, we'll talk about it. Whoever can stay, because I only have 3 more pages.
Okay. I'll stay as long as until I can't anymore.
But you can always, if you want to, you can come back between 3 and 4 o'clock. I'm gonna still be online. If anybody wants to go over the review, the concept review, I'll go over it at that point. Okay.
Okay, and that's for the test on Wednesday of next week, or which one?
Yes, Wednesday.
Okay. All right. Sounds good. Thank you.
Okay, and also I went over the terminology review. It's gonna be on Zoom later on today. It'll tell you what we're looking for on that as well. Whatever you missed earlier, it'll be on there.
Okay, yes, ma'am. I'll go back and view it. I appreciate it.
So let me move on here really quickly. The Religious America. Okay, guys. Box 11.2, 11.3. Is also pages 160 through 162, something like that. But read those boxes, because this is the Religious American. You need to know these various types of religions, their spirituality, everything we talked about in the cultural aspect of them, their food, their diet, how they perceive pain, all of this stuff you need to kind of know about these people, because you will have questions that may ask you when you're dealing with a patient of Hindu religion, do you do this or this or this or this? You need to know their practices and their rituals and interventions and all of that information. You need to know that.
Nurse Jackie, I'm sorry to interrupt. Is this just for in general knowing this, or is this for our test that's coming up?
It's both, because it's going to cover various parts of these different religions. Okay, so you kind of have to have an idea of what these different religions, especially if they're just completely different from what you've seen or what you've worked with. You know, you need to know these various religions. I would say, if I had to break this down, I would say you should know Hindu, Judaism, Buddhism, Muslim, Catholicism, Eastern Orthodox, Presbyterian, Church of Christ, Seventh-day Adventist, Mormon, Christianity, Baptist, Jehovah's Witness, very important, Christian Science. Those are definitely Muslim. Let's see, Islam. You need to know those, especially the groups that are seen mostly in the United States, which is, you need to know everything about these particular cultural groups and their religions and how they deal with death and dying and all of that. You need to know that. Let's see where we are. Western and Middle Eastern religions. I would tell you to look at boxes 11.3 through 11.7. These are the things that y'all need to be aware of: the Judaism, Christianity, Islam. Boxes 11.3, 11 through 11.7. read those boxes. Hinduism, Buddhism, nursing interventions for these groups. And that's the end of that slide there. I know it's a lot, guys. I know. That's
So,
just
just to be clear, we have a test on medical terminology and concepts on Wednesday of next week. Is that right?
yes. Look at your.
Yeah. I'm looking at the calendar. I was just making sure because it doesn't say exam or test. It just says midterm. So just making
That's what it is, a midterm exam.
Right. I figured it was a midterm exam. Just making sure. Thank
Yeah,
you.
that's okay. I mean, don't think I'm being, ugly, but
I just want to make sure. Sorry.
but it's nothing wrong with making sure. But y'all really need to look at your schedule.
Yes, that's exactly what I was looking at right now.
Yeah, because
Yes,
we've been talking about this all week. I mean,
yes.
everybody
And I
has
know.
their exams next Wednesday, correct?
Yeah, and then on Monday we have another test.
One says midterm lecture and one says midterm, which just says midterm.
Exactly.
Yeah, that's what I meant.
Okay, well, I can only say, because I'm not really looking at the other groups per se, but I know mines will be next Wednesday.
Both of them?
Terminology first and then concepts right after.
Yes, ma'am.
Okay,
And
so
then
the
on
concepts
Monday,
one is the one that you have marked as lecture.
yes.
Okay,
it's
well,
on the same day, marked as lecture.
that's a midterm as well.
Okay.
Yep. And we have a med admin term for on Monday.
Yeah, so at least y'all having your midterms on different days, so it gives you time to kind of prep for that.
Okay, and I think there's a exam 2 nursing skills exam also.
Where's that?
That one is supposed to be on Wednesday also. That's where Professor Duhan told us to put it at.
No, skills midterm is on Tuesday.